Good morning. Today we'll discuss about infectious white lesions of the oral cavity. The contents of my presentation are introduction, classification of white lesions and infectious lesions in detailed description. So there are many reasons for the development of white lesion in the oral cavity. The first reason is hyperkeratosis. Whenever there is any sharp cusp or sharp denture flange or the sharp restorations, the mucosa will react to that and it will produce more amount of keratin. So it is known as hyperkeratosis, which appears clinically white in the oral cavity. The second reason is acanthosis. Acanthosis is caused by increase in the spinous layer. So this acanthosis is seen in leukoplakia and lichen planus and in some cases of hairy leukoplakia also. The third reason for the development of white lesion in the oral cavity is intra and extracellular fluid accumulation, which is commonly seen in leukedema and white sponge nevus. And the fourth reason is necrosis of the oral epithelium, especially in chemical burns or thermal burns. The superficial epithelium gets charred and necrosed and appears white in the oral cavity. The last reason for the formation of white lesion is pseudomembrane formation by desquamated epithelial cells, fibrin inflammatory cells and microorganisms, especially candida, is the reason for the development of white lesion. So the first picture showing increased keratin or hyperkeratosis. The second picture is showing acanthosis producing white lesion in the oral cavity. And the third picture is showing intra and extracellular fluid accumulations, which is commonly seen in leukedema and white sponge nevus. And the last one is showing the fungal hyphae, which is producing the white lesion in the oral cavity. Example, candidiasis. So coming to the classification of white lesions of the oral cavity, it is based on the Burkitt's 11th edition. So the white lesions are classified under infectious white lesions, premalignant disorders, immunopathological diseases, allergic reactions, toxic reactions and other white lesions. Under infectious category, oral candidiasis and hairy leukoplakia are included. Under premalignant disorders, oral leukoplakia, erythroplakia and oral submucous fibrosis are included. Under immunological conditions, lichen planus and lichenoid reactions are included. And under allergic reactions, lichenoid contact reactions and reactions to dentifrice chlorhexidine are included. And under toxic reactions, reactions to smokeless tobacco, smoker's palate and reactions to mechanical trauma are included. And other white lesions of the oral cavity are geographic tongue, leukedema and hairy tongue. So today we'll discuss in detail about infectious white lesions of the oral cavity. They are candidiasis and hairy leukoplakia. We'll start with candidiasis. So candidiasis is a most prevalent opportunistic infection of the oral cavity. It is a normal commensal of the oral cavity. If you take a swab from a healthy person and send for culture, you can see some yeast forms of the candida, but very less number. But whenever the immunity of a person decreases, when a person is under immunosuppression, the number of candida increases in the oral cavity. It is also known as moniliasis. It is a superficial fungal infection. So it is a dimorphic fungus. It presents both in yeast as well as mycelium forms. So over 100 species of candida are identified, but all are not pathogenic to humans. Only few species are pathogenic to human, like Candida albicans, Candida glabrata and Candida tropicalis. Coming to the etiology and pathogenesis, Candida albicans is the main etiological agent. It is a very weak pathogen. The pathogenesis is not fully understood, but a number of predisposing factors are identified which convert the Candida of the normal commensal flora, a saprophytic stage, to a pathogenic organism of parasitic stage. So as I have said, there are more than 100 species of Candida. Candida species which have high adhesion property which adhere to the mucosa thickly, and species which produces phospholipases and proteolytic enzymes. So these proteolytic enzymes or phospholipases break the lipoprotein membrane of the cells, so facilitates the penetration of the fungal hyphae. So the species which produces this phospholipases and proteolytic enzymes, species which have high adhesion property, and species which overcome the constant discoloration of the epithelial cells are more pathogenic than the other species. And whenever the host immune response decreases, then slowly there will be yeast mycelium shift, and the number of candida hyphae increases in the oral cavity and produces clinically evident lesion. As I said, there are so many predisposing factors for the development of candidiasis. They are divided into local predisposing factors and systemic predisposing factors. Local predisposing factors like dentures, smoking, trauma, steroid, especially inhalation steroids, and imbalance of the oral flora are included. Under systemic predisposing factors, immunosuppressive diseases, immunosuppressive drug therapy, patients who are under cancer chemotherapy, patients who are under radiotherapy, patients who have endocrine disorders like Cushing's, hypoadrenalism, hypothyroidism, hypoparathyroidism, and in malnutrition and deficiency states are identified as systemic predisposing factors for the development of candidiasis. So coming to the epidemiology, there is large variation, and the prevalence of candidiasis is noted as 35%, and the prevalence increases in the denture whereas approximately 50% is noted. And the lesion shows seasonal variation, and the lesion increases in summers, and O blood group is considered as a risk factor for the development of candidiasis. Coming to the classification of the candidiasis is basically classified into primary and secondary. Primary candidiasis is confined to the infection of the oral and perioral structures. Systemic candidiasis along with the oral and perioral structures, it also involves other mucocutaneous areas. The primary candidiasis is again classified into acute variety, chronic variety, and candida associated lesions. Acute candidiasis is subdivided into pseudomembranous and erythematous candidiasis. Chronic candidiasis is subdivided into pseudomembranous, erythematous, plaque-like nodular candidiasis, and angular cheilitis, denture stomatitis, and median rhomboid glossitis are considered as candida associated lesions. And under secondary candidiasis, familial chronic mucocutaneous candidiasis, diffuse chronic mucocutaneous candidiasis, candida endocrinopathy syndrome, Decote syndrome, chronic granulomatous disease, AIDS are included under secondary candidiasis. Coming to the clinical features of acute pseudomembranous candidiasis, it is also known as oral thrush. So it is a classic candidial infection. It produces white curd-like plaques on the mucosa which are scrapable in nature. On the removal of the white lesion with the help of gauze, you can see a red areas or erosion underlying the white area. So these red areas or eroded areas indicate that the mucosal hyphae, the fungal hyphae, has encroached within to the mucosa. And these lesions are usually seen in patients who are under severe immunosuppressions. Patient complains of burning sensation in the mouth, and some patients complains of loss of taste sensation also. So you can see white curd-like material seen on the buccal mucosa on both the pictures. Chronic pseudomembranous candidiasis. The clinical features of chronic pseudomembranous candidiasis are similar to the acute candidiasis, but the duration is more, and it's usually seen in HIV patients and patients who are using steroid inhalers for a very long time. And the next one is erythematous candidiasis. It is also known as atrophic candidiasis. This lesion has a diffuse border, whereas erythroplakia has sharp borders. And erythematous candidiasis may be considered as a successor to pseudomembranous candidiasis, but may also emerge de novo. So palate and dorsum of the tongue are the most common sites for the involvement, and the predisposing factors for the development of erythematous candidiasis are smoking and usage of broad spectrum antibiotics for a very long period of time. So you can see erythematous areas on the tongue as well as on the palate. Chronic plaque type or nodular candidiasis is also known as candidial leukoplakia. Both plaque type and nodular associated with dysplastic changes. It is hypothesized that the malignant potential of these lesions is more because the fungal hyphae has a capacity to catalyze nitrosamines. So this is the reason for the dysplastic changes which are seen in the nodular candidiasis. The most common site is angle of the mouth. Candida associated lesions. There are 3 lesions which are associated. They are considered as candida associated lesions because in addition to the candida, they may be caused with bacteria also. Denture stomatitis, angular cheilitis and median rhomboid glossitis are classified under this category. We'll start with denture stomatitis. With excessive usage of denture, it results in denture stomatitis. There are 3 types of denture stomatitis identified: type 1, type 2, type 3. Type 1, only few areas of erythema noted on the denture bearing area. In the second type, the entire denture bearing area will be erythematous. In the third type, along with the erythema, some granulation tissue is noted in the center of the denture bearing area. The maxillary denture bearing area is most commonly affected than the mandibular denture bearing area. The second candida associated lesion is angular cheilitis. Angular cheilitis is infected fissures on the commissures of the mouth, often surrounded by erythema. So it is the candida co-infected with bacteria, especially Staphylococcus aureus is considered in the etiology of this angular cheilitis. There are many other reasons for the development of angular cheilitis like vitamin B12 deficiency, iron deficiency, reduced vertical height especially in edentulous patients, and diabetes, neutropenia and AIDS. 30% of the patients with denture stomatitis also have angular cheilitis, and only 10% of the denture wearing patients were affected without denture stomatitis. So the picture shows angular cheilitis. The infected fissures you can see at the angle of the mouth. Median rhomboid glossitis, erythematous patches especially in the posterior 1/3 of the tongue is seen. There will be atrophy of the filiform papillae and the shape of the median rhomboid glossitis is oval or rhomboid in shape. The lesions are commonly frequently seen in smokers and denture wearers and patients using inhalation steroids. So if there is erythematous lesion on the palate, if it is coexist with the median rhomboid glossitis, it is known as kissing lesion. When these lesions become more nodular, the condition is referred to as hyperplastic median rhomboid glossitis. So this is the area of median rhomboid glossitis. You can notice the depapillation in this area, especially seen in the posterior 1/3 of the tongue, and the same lesion, erythematous lesion, is seen on the tongue. So immunocompromised associated candidiasis. The candidiasis is the first most common infection in HIV/AIDS patients. And there are 3 types which usually seen in these patients: pseudomembranous candidiasis, erythematous candidiasis and chronic hyperplastic candidiasis. Coming to the differential diagnosis, lichen planus, it's an autoimmune disease and patients are healthy, usually seen in females. The lesions are bilaterally seen and these lesions are non-scrapable. Second one, white sponge nevus. White sponge nevus is an autosomal dominant disease, usually seen because of the mutations of the K13 and K4 proteins, and it usually seen in adolescents, a non-scrapable lesion not associated with any habit, and it is seen in healthy patients. And leukedema is a white alteration, wheel-like alteration of the mucosa, usually seen in blacks. If you stretch the mucosa, the white lesion disappears, and if you leave the buccal mucosa, the lesion reappears. It is asymptomatic completely, and it is associated with smokers. And erythematous erythroplakia, you can write this erythroplakia in the differential diagnosis of erythematous candidiasis. The only difference is the borders of erythroplakia are very well defined, whereas the borders in the candidiasis are ill defined, and candidiasis is seen in immunocompromised patients and not associated with tobacco habit, whereas erythroplakia is associated with tobacco habit. Coming to the investigations of candidiasis, smears or swabs are taken and fixed with isopropyl alcohol and stained with periodic acid skiff and examined under microscope. So you can see fungal hyphae, and the culture medium specifically for candidiasis is Sabrot's broth. And to differentiate different species of candidiasis, Pagano-Levin agar is used. The other investigations are imprint cultures, where a sterile plastic foam pads of 2.5 into 2.5 centimeter size are dipped in the Sabrot's broth and they are placed on the lesion for 30 seconds, and they are again cultured. And impression material, alginate impressions are used and casted with agar, especially Sabrot's agar is used. And salivary culture, 2 milliliters of saliva into sterile container and culture on the agar. And oral rinses, phosphated buffer solution for 60 seconds and then return to the original container, and again they are sent for culture sensitivity. And if there is more than 50 colony forming units on culture medium, it is considered as a positive candidial infection. Coming to the treatment, topical and systemic antifungal agents are used in the treatment of candidiasis. Coming to the topical antifungal agents, nystatin, oral suspension of 1 lakh units per ml, and amphotericin B lozenges, and clotrimazole troches 10 milligrams 5 times daily for 7 days, and ketoconazole 2% cream 1 to 2 times daily, and miconazole cream twice daily for 10 to 14 days. This miconazole is specifically used for angular cheilitis because it has antifungal properties as well as bacteriostatic properties. That's why it is used in the treatment of angular cheilitis. Chlorhexidine mouthwashes are used, which interferes with the candidial adhesion property. So 0.1 to 0.2 rinses are used. Coming to the systemic antifungal agents, fluconazole tablets 200 milligrams on the day of diagnosis and then 100 milligrams daily for 1 to 2 weeks, and itraconazole solutions 10 milligrams per ml once daily for 1 to 2 weeks, and ketoconazole 200 to 400 milligrams once daily for 1 to 2 weeks are given. So here we should remember one more point, that is azole resistance. Antifungal agents, polyenes are there and azoles are there. The chronic usage of azoles causes resistance in a patient, especially in HIV/AIDS patient. For them we have to choose polyenes like amphotericin B and nystatin. For the patients who develop resistance, you can use caspofungin 50 milligrams per day IV or amphotericin B more than 0.3 milligrams per kg per day IV. So treatment of fungus infected removable processes, advise the patients to discontinue the dentures until the lesion heals, and advise patients not to use these dentures especially during night times, and advise clotrimazole cream 1% cream and nystatin powder on the lesion, and dentures are advised to soak daily for 30 minutes in 0.12% chlorhexidine solution or sodium hypochlorite solution. The next infectious white lesion is hairy leukoplakia. This is the second most common HIV associated lesion. Hairy leukoplakia has been used as a marker of disease whenever there is decrease in the CD4 count. You can see hairy leukoplakia. It is mainly caused by Epstein-Barr virus. Apart from HIV patients who are under immunosuppression and patients who are using immunosuppressive drugs. In these patients also hairy leukoplakia is observed. The prevalence rate of hairy leukoplakia is 20% and in HIV patients it is 80%. And the diagnosis is done by clinical examination and histopathological examination. On clinical examination, the hairy leukoplakia appears as white thread-like patches, especially seen on the lateral border of the tongue bilaterally in palisaded manner. They are non-scrapable in nature. And histopathological features show hyperkeratosis, acanthosis, and some lymphocyte infiltration is also seen in the histopathology. And management, antiviral therapy is given to treat hairy leukoplakia. So this is the lesion. You can notice the palisaded appearance, especially on the lateral border of the tongue on both the sides of the tongue. Thank you.